Well, good morning and welcome to the April Mountains of Hope membership meeting. I want to thank you all for joining us today. Today's topic is approaches to increase colorectal cancer screening in West Virginia, which addresses AIM 8 in the West Virginia Cancer Plan. And AIM 8 states that we are working to reduce the incidence of mortality of colorectal cancer through screening and early detection. So we're going to open the morning with a couple of educational sessions, but first we have a few brief announcements. And we get to begin with an introduction of the Coalition's new program manager, Andy Hazley. Andy's been with Mountains of Hope for about a month now, and I'm sure you've seen her name on a few emails already, but today's her first membership meeting, so we'd like to extend a warm welcome to Andy. You will be getting to know each other better in the coming months. And in other news, Mountains of Hope subcommittees took on a variety of projects in the past year. Despite the pandemic, despite having to adjust pretty much your whole lives, the coalition came together, and I am happy to announce that all the subcommittees are on track to complete their projects by June 30th, which is going to leave us ready to begin a new grant year at our next membership meeting in July. So congratulations, subcommittees, on all your progress. Some highlights of the work that's been coming out of the subcommittees for quality of life. The Cancer Resource Guide has been updated to include food banks to address food insecurity for cancer survivors. We invite you to check out the new logo. It's got a makeover as well. And to share the updated resource with your networks, I will put a link to the resource guide in the chat. And with the resource guide, we're also doing a little bit of cross-pollination with the early detection subcommittee. So one place that's going to be highlighting that new resource is the Ribbons of Faith training, which is a free cancer awareness training for faith leaders and parish nurses. It's going to be held online May 18th and 25th from noon to 2 p.m. And we invite you all to share this information with your faith community if there are leaders that are in your social network that would be interested. And I will put a link to the Ribbons of Faith registration for you. And that is up. Prevention Subcommittee is purchasing cookbooks that feature low-cost, high-nutrition recipes geared for SNAP users, with most meals in the cookbook costing around $4. And they're going to add these cookbooks to the cancer education materials for Mountaineer Food Bank in Mendon, West Virginia. In other work, the Take Pride in Your Health West Virginia, which is a Mountains of Hope collaborative campaign, has partnered with Covenant House, the Dr. Rainbow Project, and the National LGBT Cancer Network to address cancer-related health disparities for West Virginia's LGBTQ population. There are 5 PSAs in route with a way to link the community through advertising to the Dr. Rainbow Project, where they can find welcoming providers throughout the state. And the campaign is scheduled to launch in June. And you would think that's enough, but no. Getting all of this stuff done requires people to take the reins and lead and make sure we have that happening. And the nomination committee has been incredibly busy identifying candidates for all of our open leadership positions that are coming up. So an official ballot will be distributed to the membership electronically after today's meeting. Please watch your email and vote, because we were only going to leave that open for about a week. It's going to be sent out. It'll be quick. There's one candidate for each position. It shouldn't take a lot of time. And then we will get those people into their positions and ready to go. And these are just a few highlights of the coalition's work. So if you're looking for some more complete updates on subcommittee projects and other things that are happening, you can always go to the Mountains of Hope website and access the steering committee meeting minutes where the updates are written out for you. Or you could always stay for the breakout sessions this afternoon. So it has been my delight to serve as chair of Mountains of Hope for the past 3 years. And one of the perks of being the chair of the coalition is that I get the opportunity to share information about the great work that you all do. To that end, I'm going to be presenting at the Prevent Cancer Dialogue Conference on May 5th at 3:30 p.m., highlighting the coalition's work with lung cancer screening. The conference is virtual, it's free, and everyone's welcome to attend. And I'll put a link to the registration page for that conference in the chat. And that concludes today's announcements. Thanks for putting up with a little interruption before we get started. And to introduce our first speaker, I'd like to present to you Mary Ellen Kahn, the Program Director of the West Virginia Program to Increase Colorectal Cancer Screening. Mary Ellen.
Thank you, Shelley. Good morning, everyone. I am a longtime member of Mountains of Hope and also serve on the Early Detection Work Group. And to give it, for those of you who are new to the coalition, just to give you a little bit of background information, Mountains of Hope, in partnership with my project, the West Virginia Program to Increase Colorectal Cancer Screening, the American Cancer Society, as well as many other partners, have been actively working over many years to bring a colorectal cancer summit to the state level. We hold those meetings every other year. So we've had them in 2017, 2019, and now again this year. Due to COVID and everything having to be in a virtual format now, we could not meet in person as we normally would with these meetings. And so bringing the summit and the educational information and presenters, bringing it to a Mountains of Hope membership meeting is really one of the benefits of having these partnerships and being able to get this information out to as many partners as we possibly can. So I thank you for joining us today. I have the honor of introducing our first speaker, Dr. Whitney Jones. He is not new to presenting to Mountains of Hope. He has come and talked to us at various times before. Dr. Jones is a practicing gastroenterologist and an adjunct professor at the University of Louisville School of Public Health. He founded the Colon Cancer Prevention Project, which is a leading colorectal cancer information advocacy organization, which is focused on accelerating evidence-based screening, including emerging biotech and logistics. One thing through some of the work that that organization has done, we see that Kentucky has since more than doubled its screening rates, and they have reduced their colon cancer deaths by 1/3. A major focus of the Colon Cancer Prevention Project is advocacy, and they do that through passing pragmatic state-based laws, which lower barriers to access to screening. And they have also worked on providing funding for un- and underinsured Kentuckians to get colorectal cancer screening. Kentucky is the first state in the nation to mandate a no-cost sharing coverage for insurance for preventive evidence-based genetic panel testing for hereditary cancers, including Lynch syndrome. And so these laws and other advocacy work that they have done have resulted in Kentucky having the lowest barriers for colorectal cancer screening in the nation. So please welcome Dr. Whitney Jones.
Hi guys, thank you so much. And hi to all my friends out there from across the Southeast. I'm gonna bring my screen share up here. And let me know if you guys can see that. And then I'm gonna get my slideshow started. All right, can you guys see that okay? All right, great. Well, again, thanks again. What a wonderful, warm introduction. Thank you for that. I feel like I've already done a day's work with that kind introduction. And it's my honor to be here today to not only speak to our neighboring state, but also share the stage with my good friends and colleagues in South Carolina. And, you know, I really love South Carolina because they've shown the way in so many areas that I think are going to be helpful to states, particularly in terms of coalition building. And we've had different models in states, but we've had quite similar success in really raising this up. So today I'm going to talk a little bit about how do we shift West Virginia from defense to offense against colorectal cancer. I think we've all feel like we've been on our heels. I was been traveling in the Southeast lately, and I think all of us in the cancer prevention screening space, I think we could all do with a good power washing and a knock on the head to get back into our world. I think we've all been in that COVID zombie land for the last year. And again, it's a bad virus. You know, I hope everybody's had the opportunity to be vaccinated. but we have to learn to walk and chew gum at the same time as our states are ridden with cancer. And, the deaths from our state and West Virginia's certainly outpace the COVID crisis that we've been through. Here are my disclosures. And the objectives of today's session are to discuss strategies for effectively communicating colon cancer screening messages and engaging stakeholders. We're going to review the use of legislations, regulations, and appropriations. And then finally, we're going to focus about the last half about reviewing the challenges facing West Virginia and many of the southern states as we increase compliance with current evidence-based screening, taking into account what is coming down the road in the future. Because I think if we don't embrace the new technology, whether that be informatics and logistics, as well as genetics and biotech, I want to see the Southeast being the region of the nation that is the earliest adopter of these evidence-based issues, not the last. So this will tell you over the last 17 years, we founded our organization in 2003. I thought it'd be a couple of year project. Little was I aware the true investments needed to be made at the state-based or national level. But this generally shows you what happened. We were 49th in the nation in screening. We've improved as high as 17th. We now hover around 20 or 22. But what's important is our mortality rate is down over a third. Our incidence rate is down 28%, which promotes the importance of prevention of colon cancer through screening, not just early detection. And each year that translates into about 650 people either not getting colon cancer or not dying from colon cancer in the state of Kentucky. So how did we make progress? Again, we've had long-term cross-sector collaboration, health departments, comp cancer, nonprofits, health systems, advocacy, providers, physicians, legislators, lobbyists. We have a full-time lobbyist who works for us. And comp cancer sits here right in the middle, really bringing all of the people in the cancer world around the table. But we've also really worked hard on policies that reduce barriers and expand access. And we'll talk a little bit about that as we go on. But this first part is just about communication. So one of the first things, we did our first roundtable in 2008. As part of that, we began to really focus on colorectal from the consortium standpoint. And we developed a resource plan. And I'm not sure if West Virginia has one. I suspect you do, since you're a CDC organization. But we came up with these numbers, which for every $100,000 we would invest in cancer prevention, what could we do versus what could we do if we invested $100,000 in cancer treatment? So for $100,000 in cancer prevention, we could do 246 colon cancer screenings, and we could treat one versus treating one person for late stage colon cancer. So I think these are effective tools to communicate with legislators and people in power positions, but also important to continue to push that focus of prevention and early detection. And again, this runs across the various cancer spaces that are involved with prevention. These partners then took these policies and plans and put them into action. We have an organization called the Kentucky Cancer Program, split between East and West in Kentucky. And they did a Get the Fit Facts as we tried to improve understanding about stool testing, because we were very colonoscopy driven back in 2003. We used the Behavioral Risk Factor Assessment Program to gather data and create fact sheets and presentations that we put into local health departments, as well as community health centers. We trained the local health department staff initially to serve as patient navigators so they could push those into programs. Our organization, the Colon Cancer Prevention Project, over 2 years went to 96 FQHCs across the state in Kentucky, bought them lunch, gave them a scholarship, taught them about how to assess people for colorectal cancer and how to use a blended strategy based on shared decision making. Now, even though we're still the #1 state in the nation in colorectal cancer incidence over a 5-year piece, despite this work, I think we are #1 per capita on the number of inflatable colons traveling around Kentucky. And these are great tools, and I'm sure you have one, but you can't have too many in terms of increasing buzz and awareness, and I know we'll get back to that in the COVID space. And finally, our Kentucky Cancer Link, which is really our navigating partner to services for the state, is linked with our NCI designated Markey Cancer Center and helps distribute fit kits, navigate patients to colonoscopy and stool DNA. So one of the big questions I'd like to throw out there is to silo or not silo. That's the question. And, you know, we talk about cancer as a big group, and Whether or not having an organization in your state that really focuses on colorectal cancer 24/7, 365 versus having it completely integrated and just one of the pieces in the cogs of the wheel, I think is a real question. But I would suggest to you, and again, South Carolina is a great example of this, the states that I believe that have made some of the major progress have specific 501c3 organizations that focus on colorectal cancer 24/7, 365. And so siloing has positives and it has negatives, but I think when you take a cancer like colon cancer that's been sort of at the back of everybody's list for many, many years, I think siloing has been very effective, and I would certainly throw that out as a consideration. But what really worked with us in terms of driving change, and again, these gears, are the public-private partnerships that have developed. We have an organization called the Kentucky Colon Cancer Screening and Prevention Program Advisory Committee, and that's staffed by the Department of Public Health. It sits within the Cabinet for Health and Family. And all of these great organizations that you'll recognize, American Cancer Society, our universities, the Department of Medicaid, the Department of Insurance, congressional appointees, the Primary Care Association that oversees all of the community health centers, the KMA, the KHA, some independent appointees by the governor, as well as our consortium and our registry all sit there. And they interface, as well as other members, with independent 501c3s based in Kentucky. Because what's really critical is these folks on the left of your screen, they can educate and they can be involved, but they cannot advocate because they are usually involved with state or federal funding. These organizations on the right can do a lot of things outside of the box in terms of advocating for policy as well as funding. And again, the way these two organizations work together, I think has been one of the key issues in driving change in Kentucky. One of the other pieces we'll touch on is old communication pathways. You know, when I started, it was TV world and radio and pamphlets. And so we did a bunch of pamphlets. Almost 2 million were distributed across Kentucky and the Southeast on our early issues, handouts, traditional media, academic detailing, community events and churches still play a great role, but again, certainly challenged during the COVID. And I think in the old days, we used to have to try to get a single great message delivered once that would drive 50 to 75-year-olds. I think what we're coming into is the new media where we're going to be using digital and social. We try to reach younger people in messaging, and as well as folks who will be eligible at 45. These folks are on their phone, and we have to reach out and engage people where they are. We're going to have to start using databases more aggressively instead of waiting for an opportunistic moment of screening where doctor meets patient, doctor remembers everything he has to do and then recommends it and it gets done. We have to work harder to provide some choice architecture where this happens. So that's bringing in health systems and insurers to take a little more of a lead and a little more of a risk. One of the other big issues is lead time messaging. Everybody is on this Zoom call today and at this meeting because you were contacted well in advance and reminded multiple times and given instructions on where to be and what time to be there. We need to take cancer screening as seriously and begin to message people earlier so they can take advantage of that prevention pathway. And again, where people are, again, whether that's in churches, whether that's in schools, whether that's in digital line, it doesn't matter. We have to get out there. Traditional medicine is going to be changed as this new reset around the digital healthcare world continues. And again, we'll talk a lot in the last half about this 35 to 55-year-old being the new 50 to 75 in terms of messaging. One of the things we did develop this year is we had many groups pushing out messaging is we developed core messages because it's impossible to give all these messages in any one particular tool. You might get 2 or 3 messages in, but we wanted to make sure that if you were delivering messages across all those organizations that are out there delivering it, that they had the exact same messages. So we weren't confusing screening with just colonoscopy. We were talking about the test that's best for you. We were talking about early age onset colon cancer. We have laws that allow us to screen at 45 for commercial insurance for several years now. So that's been no particular issue. So again, making sure that you have messages that are extremely confluent and consistent, even if you're having organizations put their own specific twist or spin on them, is really critical. We've got a few add-ons as well. We've really worked hard on documentaries. We've had 3 on public television that aired almost 80 times each over a year. There's a great talking cancer card for FIT education, where a survivor and a person who had their cancer detected by this, it's one of those little things like you would open it up and like a birthday card, and it gives you the FIT-SEBEC. So that's really great, and you can reach out to us and we'll connect you with those guys. We've had multiple elected officials, public service announcements, the pamphlets we spoke about, our 2 universities, UK and U of L, as well as Pikeville Medical Center, which is a DO place, have been on the ground really, really working hard. We've got a couple of CDC grants going on in 2 community health center settings, lots of earned media, and I think we like to talk about every month is March for Kentucky in terms of pushing that message. In terms of earned media, this is a great guy here, Dr. Wayne Tuckson. He's a colorectal surgeon and has been relentless about pushing colorectal. We do a podcast every month or every couple of weeks. And more recently, we were able to be a grant recipient from Exact Sciences to have a Cologuard kits to be able to put those into our package for the uninsured in the state of Kentucky. Another big resource I want you to think about when it comes to communication is your Kentucky Hospital Association, or the West Virginia Association in your guys' space, because many physicians are employed by hospitals, and it's a very organized area where many of the benefits of increasing screening develop win-win organizations in terms of driving business, finding cancers, the surgeries and endoscopies that are needed to detect and treat those. And we've used them over the past 2 or 3 years. Use them is not the right term. We've partnered with them to really deliver our messages. And what we've been doing in advance of the USPSTF recommendation, and we think that's going to come out in the next couple of weeks to lower the age from 50 to 45, is we've been trying to get those guys conditioned for that. In terms of, in Kentucky, they adopted the ACS, but again, not so much in West Virginia, as that's not part of your state guidelines. But 45 will be there. So start working on your electronic health records to transition them. We wanted to make sure that all of the hospitals in Kentucky were already offering screening at 45 to their individuals. So again, as soon as that flips in the next couple of weeks or months in West Virginia, giving those guys advanced information, because I think people universally think that USPSTF, based on the data, is going to drop that age from 50 to 45. And making sure that coders understand that 45 will be a screening examination. And who are we talking to? Primary care, OB, GYN, surgery, oncology. Secondary issues that we've really tried to work on are mining electronic health records to identify people who've missed screenings during the COVID period or just hadn't been screened at all, and reaching out to those guys and offering them a screening. One of our organizations, sorry about the pups out there, I guess they escaped. One of our organizations, St. Elizabeth in Northern Kentucky, mined their EHR and were able to deliver 19,000 stool DNA tests based upon people who had not been screened. Excuse me 1 second here. Hey, Keith? Will you help me with the dogs, please? All right. So in the secondary piece, we've asked our hospital association, knowing, and I'll talk a little bit about underage 50 colon cancer, but we talk about Kentucky, we're talking about West Virginia. So instead of driving that message traditionally to the 50 to 75-year-olds, driving that demographic to the younger folks, the 50 to 75. Also, we've talked to them about broadening their genomic footprint just beyond treatment and utilizing KCCSP resources for the and underinsured, so they can not only encourage them to become a screening site, but also knowing that that's available. Yes, right here hanging on the door. Thanks. So one other thing we share, sorry about those. This is the land of Zoom nowadays, and we got kids at home and dogs and business. So, but one other issue we really share in common is our young colon cancer and Appalachian issues. In Appalachia, you can see here in the red, and in the rest of Kentucky in the blue, you can see that back in 2000, they had lower rates of colorectal cancer than the rest of Kentucky. But over time and up to 2017, we see this dramatic divergence between Appalachia and non-Appalachian populations in Kentucky in terms of colon cancer incidence rates. And I would be almost sure that's the same in Appalachia. Equally and more disturbing is what's going on with young colorectal cancer in our states. And what we're seeing here is, in fact, the red line is Kentucky versus the blue line, which is the rest of the United States. So young colon cancer is going up across the country, but in Kentucky, we not only started approximately 20% higher than the rest of the nation, we are diverging again to where we almost have 30% higher rates than the rest of the country. And when you break that down, and I'll have more data about this and where you fit in this Appalachia, but if you break that down into just Kentucky alone, again, the non-Appalachia Kentucky here in the blue is going up, but the Appalachian part of Kentucky not only started higher with under age 50 colon cancer, but is actually getting worse and diverging. So these are critical issues as we move ahead of communication, and it needs to shape our communication from the traditional 50 to 75 demographic. So let's talk a little bit and shift into policy here. And these are some great guys. This is Jason Baird, our lobbyist. This is Dr. Tom Tucker. He heads up our cancer registry, critical and pivotal to our work. And this is Elaine Russell, and she is the head of our cancer consortium in Kentucky. So the guiding principles for what we've been able to do in policy is the what. We only work on evidence-based, operational, pragmatic topics that have a high probability of success. Why we do it at the state level is we think it's achievable and accessible, and we can build momentum. The federal government's been pretty broken until this year when they made a breakthrough on the polyp loophole, but we may see more under this administration. Who at the state level? Again, independent 501c3s with a government lobbyist are able to go up there and advocate. The ACS has been great, but above and beyond that, most of the other people can serve as educational tools, and they can be in those rooms, but they can't do the more aggressive lobbying, the more face-to-face. But again, all of those people who we talked about on the advisory committee are critical to the educational process of folks in the executive and legislation branches. So how do we do it? We find a bill sponsor, we have a goal in mind, we get them to help us with the executive branch. You don't want a bill sponsor that everybody hates, even though he may be the best advocate for what you're trying to do. And we talk to everybody who it's going to affect, including insurers, hospitals, physician associations, and almost all of the ones have fiscal impacts. And so you can't escape them. The budget committee decides. So then we gather support. We try to maintain that support and follow up because things change in politics. This was a Governor Bevin, who is a friend of President Trump's, and that flip-flapped completely in our state. And this governor right here vetoed our funding for our state program, and it took us almost 3 years to get back from that. But the next time he vetoed it in our budget, our legislators overrode his veto. So building and maintaining that coalition is critical. Here's just a pic of our few guys, and I don't go through them all, but they're too numerous to meet. But again, so this is a little walk through what we've done, okay? And you'll see laws, appropriation, and actions, because one thing a government relations guy, it's not all about a law. There are many other things that we can do. So in 2008, we mandated insurance coverage for colorectal cancer screening. We created the Kentucky Colon Cancer Screening Program with no money. But critical, we created this advisory committee, which has met every month for 13 years now. And that's where that driving group of people really come together every month. We got some cold severance money early in our work. And then in 2012, we actually formed a nonprofit organization called the Kentucky Cancer Foundation and raised about $750,000. And that helped prime the pump for our state to put in $500,000 a year to really start funding the program. Again, nothing's there in politics. We got vetoed, refunded in 18, but again, that crushed our program for several years as those state contracts, as you know, take years to develop. We were initially in the Medicaid quality metrics. We've fallen off that. We're working to get back in that, but that was a chance for us to engage with our Medicaid folks. And then we really had the mother of all policy change, which was the Medicaid expansion, which increased our screening rates almost 5 to 6 percentage points for the state. We later closed the polyp loophole in 2015. So if you have a polyp found during a screening, it's still a screening colonoscopy. And we switched the definition of a continuum of screening. So if you had a stool test that was positive, that colonoscopy was considered a screening completion colonoscopy rather than diagnostics, as it should be. And that's still been a major issue that we've had to backfill and work on over the years. We're still not done with many of our payers. In 2017, we unlinked genetic counselors from licensing and where they had to be located in a health system. Now they can be independent because we saw the human resource needs to bring more genetic counselors into the state of Kentucky. And then finally, in 2019, we passed the Awareness to Genetics Testing Act that made genetic panel testing based on NCCN guidelines for hereditary cancers a covered service with no out-of-pocket cost sharing. So a lot of work, but we weren't done. In 21, the past 2 years, this year, we passed Senate Bill 16, which kept our program from getting funding sweeps from what we have in our bank account. We added prevention, we added the Department of Insurance and Medicaid, and we allowed for a license plate to help us with funding. We also passed House Bill 108. And again, I was these felt sort of soft to me, but our lobbyist, Jason Baer, was critical about this. And what it essentially did was mandate that our colorectal cancer and genetic coverages were going to be utilized by Medicaid vis-a-vis the Medicaid MCOs going forward. So what that meant was if we had an administration change or a change in the leadership or different Medicaid MCOs that came into Kentucky and bid, that they would still have to follow and cover these tests as previously written. And that protects about $21 million in colorectal cancer screening, which is delivered now through our Medicaid services. Again, the genetic panel testing, I can't emphasize that every state, but especially the Southeast and Appalachia, needs to wrap your head around how we get more engaged. There is tons of research about this. This is no longer Star Trek stuff. This is evidence-based and guideline-driven. The problem is there's low awareness and comforts amongst physicians because the technology is moving so fast, and there's not a lot of postgraduate education or even education in medical schools. And likewise, everyone worries about how much money it may cost, although the vast majority of people undergoing panel testing have it as a covered service, and now more so in Kentucky related to our legislation. So unfortunately, that leads to very little action. Only 1 in 10 patients with Lynch syndrome are identified before their first cancer diagnosis, and only 20% of women who meet criteria for hereditary breast and ovarian cancer syndrome, or the BRCA genes, are getting tested. And BRCA affects about 1 in 400 folks. Lynch syndrome affects 1 in 279 people. So it's probably the most common cancer mutation. And we know there are founders effects in Appalachia, particularly in Eastern Kentucky, but likely in West Virginia, given our proximity, that make Lynch syndrome a real issue. And we're working on universal Lynch syndrome tumor testing around colorectal cancer and doing some research around that right now with Dr. Tucker. So, but everybody's got to get in the game and integrate genomics, genetics, cancer family history into their plans. In terms of guidelines and the political space, we fully expect, again, the U.S. Preventative Task Force Service to come to 45 in terms of initiation of average risk screening within the next couple of weeks. I've heard a couple of weeks, could be a month. Again, states have up to a year to implement insurance plans, but at least we're not going to have to go through this mosaic of which states follow ACS and which states follow USPSTF. So one take home is start talking to your insurers and your hospital organizations. They have electronic health records. There's lots of modules there where they can flip a switch and have those prompts and everything switch to 45. Get them prepared so it doesn't take them a year to do it. Because when we go over the state by state under 50 colorectal cancer piece, you guys are in the crosshairs. Again, just a little information about the impact of our Medicaid expansion. And again, I say coming to a state near you. Certainly seems like that's part of the national policies that are being pushed. And again, in Kentucky, there's no question it had a major positive impact. Our pre-expansion spending on colorectal services was about $6 million with 28,000 claims. And you can see the next year, in 2 years, it had almost tripled. And only gone up. So it's up 334% in terms of our spending and about 251% in terms of the claim count. And there's no doubt that this is a critical issue for us, because now in Kentucky, with our state program as well as our Medicaid expansion, there is no one that does not have full coverage for colon cancer screening, including completion colonoscopies. We also provide surveillance colonoscopies for people who are underinsured, whose deductibles are excessive, so we can keep those guys out of trouble as well. And again, no longer is this sort of we used to have a saying, saves lives, saves money. But we really sort of were making it up. I hate to say it, but we certainly thought it would be less. But now we've got some data from Dr. Tucker at the registry that suggests that yearly savings related to our increases in screening and surveillance and our rates, again, reducing those patients. And this is only based on prevention. It's not even based on the downstaging. We're saving at minimum almost $41 million a year in treatment costs for advanced cancer. And again, that's really a number that legislators can wrap their heads around. So I'll pop through that. And so let's flip into the last part, which is what are we going to do now? We're on the tail end of the COVID, or at least we all hope. Colon cancer is dramatically changing in terms of its demographics. We know that our messaging at 50 wasn't doing a good job for people at high risk based on family history. We knew we weren't doing a good job on educating people about the symptoms, and 60% of people who present with colon cancer under age 50 don't have a family history. They present with symptoms. And more importantly, we weren't doing a good job of getting people screened on time. Less than 50% of people are getting screened between 50 and 55 years of age. And I like this picture because you may recognize Chad Bozeman here, and he got colon cancer in his late 30s and died tragically in his early 40s. And he stands here next to Stan Lee, the creator of Marvel Comics. And I can't tell you how much effort and time and money we spend on getting a guy like Stan Lee to get screened, and how little time and effort we have spent over the last decade educating folks like Mr. Bozeman about signs, symptoms, family history, risk factors, the critical nature. And so because the face of colorectal cancer screening is changing, we have got to adapt our approach to the future and develop a complementary, not competitive messaging strategy that includes lead time messaging with our goal of on-time screening. Again, we're all 75, 80 of us here on this Zoom meeting because it was important enough for us to get ahead of it. So we've got to work this problem backwards. At a national level, 100 million people are going to be at risk for colorectal cancer screening. And if we want to get them to get screened on time, we know what we want. We want high-risk people to get it at 40 or sooner. We want normal-risk people to get it starting at 45. How many messages does it take to get a screening done? I don't think you can give one message and it tells people to do it. A Big Mac probably takes 7 to 10 messages, and it's yummy and got a lot of calories and appeals to all that lizard brain. But you got to realize, can you get a message out once a year? Does it take 5 issues? Identifying high-risk people is really critical, because if we're starting early enough to identify high-risk folks in their 30s to get screened at 40, we'll have more frequency of message delivery to the average risk folks, and that's a bonus. And right now, I think we've been talking to people where they don't get their messages. You know, men don't go to doctors until they're 40, 50, 60. They're not getting messages early. Health networks are pretty good at getting them out. Insurance companies sometimes do a good job, sometimes not. Media is changing, and men are particularly, I think, one of the big groups of disparities that we don't even really talk about or isolate, because unlike women that have interactions with the healthcare system because of reproductive issues and motherhood, et cetera, men have no early detection or even experience outside of going to urgent care clinics or health physicals well into their 50s. And by messaging people more frequently and earlier, it's a huge potential for us to better address health equities and disparities. And there's are great researchers, and Dr. Berger is a great researcher, led a lot of the team in South Carolina, about why are we seeing all this early age onset colon cancer. My issue is once we solve it, we're still going to have to learn to talk to 30-year-olds and 35-year-olds and 40-year-olds to help pass that message on to them. So learning to speak to people earlier about colon cancer is critical. Imagine if people had as much awareness around colorectal cancer as women have around breast cancer that starts in their teens, 20s, 30s, really ending in the successful programs around breast cancer screening. So this is a little piece to bring this home. The squares in these boxes are 20 to 29, 30 to 39, 40 to 49, and 50 to 54. And what you can see is colon cancer screening is going up in all of those folks. So colon cancer screening is only really going down in the over 55 population. It's going up in the under 55 population. And I just read some data. Right now, colon cancer is the #1 killer of men under 50. By 2040, it's going to be the #1 killer of men and women from a cancer standpoint by 2040. And so this is critical for us to wrap our heads around and use in the planning as we go forward. Now, here's some data I've been looking at, and this is preliminary, but over here on the left column, we've got the states ranked by their burden of colon cancer. So their rank in terms of national statistics, in terms of incidence plus mortality, and that gives them a rank of burden. And then over here on the right side is their rank for under age 50 colorectal cancer. And isn't it surprising that 8 out of the top 10 states for overall cancer burden are 8 out of the top 10 states for under age 50 colon cancer? And if you look at the next 10 states, 7 out of 10. And let's see where West Virginia is here. You are #1 in the nation for under age 50 colon cancer, and you are #2 in the nation for overall burden of colon cancer. But again, look at this Southeast here. Alabama, Arkansas, Louisiana, Kentucky, West Virginia, the same old players in there. South Carolina is #10 for you guys, but you're doing a great job, and that's maybe because your screening rates have gone up, but you're not in the top 20 for the overall burden. So if you're not focused on the early colorectal cancer, in addition to our general messaging, you're not leading the target in terms of what's coming into your state over the next 2 decades. Again, screening rates at age 40 and to 45 or maybe 20%. We're probably doing less than that in people who are high risk that need to be screened at age 40 or sooner. And for those sporadic folks, if we don't inform them, normally what we're seeing now are 3 to 12 months of a person not recognizing the symptoms of colon cancer before they make an appointment. And because doctors are not aware, as they move into the provider space, doctors may delay this another 1 to 2 months because we're not educating these guys about the under age 50 piece. So there's a huge delay in the colon cancer diagnosis. Our goal ought to be to drop this down so people are aware, they get to their doctors immediately, and those doctors know to refer them immediately into an appropriate cancer diagnosis guideline. So I think today, with our current screening guidelines, and I'm going to say 45 is current because it is in Kentucky and it will be soon in all your states. With the current tests that we have, here's things we don't have to do to really get ahead. We don't need new guidelines once we get through that. We already know who the elevated risk groups are. We don't have to study if guidelines work. We know they work. We don't have to reinvent family history. We just have to learn how to collect it and apply it. And we know that marketing works. And we don't have to do new testing options, although they're certainly coming. We have all the tools we have right now to address well over for 50% of the under age 50 colorectal cancer. But more options and strategies are going to be coming. And let me tell you what, you better strap in, and they are coming to a town near you. I would say that in the future, probably all stool testing will likely have a DNA component or an extended component above FIT. Septin-9 blood tests were turned down, but they're coming. Bigger on the screen are what are called multi-cancer early detection tests. They'll be coming to market this year, and they'll be pushing for CMS approval and payment structures. And these tests find not just colon cancer, but depending on the manufacturer, 12 to 50 cancers. And again, they're sensitive to about 60%, meaning they'll pick up 60%. but they're very specific, up to 99.5% specific, and they'll tell you where the cancer is, not just that you have it. So please start educating yourself around molecular and multi-omic technology. So what we really have is a big, hairy, audacious plan, right? We talked about a BHAG, and Jim Hotz talks about it at the roundtable, a big, hairy, audacious goal. Well, if you don't have a plan with your big, hairy, audacious goal, you're not going to go anywhere. So I think today we have the data, guidelines, and screening tools to make a difference. And the way to get to 80% on time for every risk group is a way to get to 80% in every community. Because if we're not focusing on young colon cancer or the early average risk folks, we're making a mistake. And so we've got to reset our target demographics as a national issue. And this is going on in discussions at the roundtable right now. We need to start messaging at least 5 years before family history screens are needed. In fact, we need to be educating people in their 20s about primary prevention, smoking, diet, obesity, understanding their family history, recognizing symptoms. We have to start early enough to deliver message frequency and including hard stops. And so we can affect 50 up to 75% of early age onset cancer now. We've got to fund clinical research to figure out how we do it so we can get more evidence around it. And we've got to elevate cancer family history in the electronic health space. Because what's going to happen, guys, in public health world, if we don't figure out how to do this, do not be shocked if guys like Amazon and Let's Get Checked and Let's Get Screened take this completely out with logistics and a flattened, more democratized screening stuff where this stuff's being done at home. So some of the things we've done around this is Medicaid covers at 45, as well as preventative genetics. Our biggest health system adopted Epic and EHR at 45, which was great. St. Elizabeth's leveraged 19,000 take-it-home stool tests, which were Cologuards, over the last year, and they did that through database mining of people who didn't have a screening code as a way to make up and catch up for COVID. Our state government covers at 45. United Healthcare, if you want to look up insurance policy, they have the best insurance policy around colorectal cancer screening. So we continue to work on that, as well as universal screening for Lynch syndrome. And again, this linkage for colorectal cancer for 2020 and beyond is going to be driven by this under 50 pieces. We already see it in our states. So I'll finish by talking a little about what we're doing in a digital program in Eastern Kentucky. And someone asked me at the roundtable yesterday, well, how do you know that this is going to work? And I said, well, I don't know that it's going to work, but I can guarantee you younger people getting messages is going to be more than they've ever received in the past, because we've messaged at 50 forever and they've never received it. So just like West Virginia, we have hotspots in Eastern Kentucky. And two of these bluest areas are called area development districts, the Kentucky River and the Cumberland Valley districts over here. And we know it's a hotspot for underage 50 colon cancer. We know it's some of our lowest screening rates in the state. And we know we have some of our highest percentages of Lynch syndrome over there. So what we did is we came up with a grant where we partnered with Kentucky Cancer Foundation and CancerLink, two of the nonprofits, as well as the project. And we decided to go where people were in terms of messaging, which in our, for this particular pilot, was digital messaging on the computer. So we did focus groups. We did 3 focus groups in Eastern Kentucky with the help of the Kentucky Cancer Program. We did numerous iterations of these advertisements. But again, you can see here's some sample ads. We have 8 total. I'll just show you a few. Don't sit on it, because again, we know that 60% of people with under 50 have symptoms and they don't have family histories. Not just your grandparents' disease. Again, we're focusing on early colorectal cancer, showing that it's a family issue, not just these 2 folks who would be our normal targets, but in fact, these 2 folks in the middle. Basketball is huge in Kentucky, so we had to have a basketball piece in there. Don't run out the clock, Kentucky. Get screened for colon cancer on time. Learn about your options. Hunting and fishing, huge here. And we initially had a gun, but our focus group told us maybe guns aren't the right message, but hunting and fishing certainly were. So be the hunter, not the hunted. Colon cancer's on the rise in Kentucky. Don't let it sneak up. And then each of these, and we have several others. We have a fishing one. We've got an ATV one. We've got a couple of different family ones as well. And again, they're not available on our webpage. They're just coming through. But also we're geo-fenced. So if you're around a healthcare facility in one of those counties or zip codes is how we did it, that you'll get a message if your phone or device pings it in an area around a hospital, et cetera. And then if you open it, we also will send you follow-up emails. And so far we've done great. The normal click-through rate is about 10% and we're about 25%, so we're more than double. And our open rate on our emails is almost 20%, which is far above the national average for advertising campaigns. So once you click on one of those, you come to our landing page, and we've got a beautiful picture of Appalachia. This looks like the breaks to me. Again, it gives a little bit more information, and then it goes on to some additional prompts. Again, it talks about, are you at risk? We've got some simple things about higher risk people, the importance of learning your family history, and over here, average risk, screening at 45 with all your choices, whereas higher risk, and we have an iteration of this that actually shows that if you have symptoms right now, you need to be screened, and that's in bold and red. So, and again, we direct people towards our program for the uninsured, and you can click this link and it'll take you directly to our navigator. And this piece right here is related to a service piece. We have a map of the state by counties, and if you click on your county, it'll take you in a hyperlink to all the service providers in your area in terms of gastroenterology or hospitalization or endoscopy clinics. And so we'll be able to link those issues. I think our first issue is, are we reaching people? Are they getting to our homepage? Are they checking out resources in the area? Phase 2 of this will probably be partnering with institutions in these areas to understand what's driving or how much it's driven their volume in terms of colonoscopies or presentations with bleeding or other symptomatic presentations. If this is successful, we're already planning and doing a focus in our large urban area, Louisville and greater Louisville, that'll have a more urban focus message with Hispanics and African Americans. And again, that'll be based on zip codes. And so again, we really think this is sort of how we're going to reach these guys. And this mirrors a lot of what they're studying at the American Cancer Society and NCCRT. So hopefully we'll be able to share that data and work with them. So down the road, again, what we used to do is start our messaging right over here at 50 on the far right of the screen. And that's really where we paid all of our attention. But if we're going to get folks screened on time in the new 45 world or the 40 world, if you're a high risk, we've got to be able to start talking to people in this 35 to 40 range, and more critically, start that conversation earlier, a la breast cancer education and awareness, where we're talking about lifestyle modification, which is critical in Kentucky and West Virginia around obesity and smoking and diet, the critical importance of family histories, as well as teaching people about identifying symptoms and what to do when they do. So in the past, we've spent a lot of time over here and almost all our money at 45 to 50 and above. And really what we've got to do is develop better this early messaging package and reallocate resources over into this space. Because my theory is the more work we do in education over here about getting people screened on time, the less work we'll have to do over here and the higher rates of compliance we will have to do. But again, we're looking for data. This is new thinking around this old problem. So I sort of look at our world like this, where if we get out there and we talk to people about primary prevention, maybe having 2 tacos instead of 6, lifestyle prevention, not smoking, that's the furthest out shield that we need to be to help people from getting colon cancer. Sort of into this next level are the genetic counselors. We want to talk about family history, including polyps and advanced adenomas. You really bring genetics into the place. So by the time that you get to that on-time date at what will soon be 45, we've really built quite a fortress, because right now people are crashing through our defenses in that 50 to 55 range for screening, and then down the road work for surveillance. So I think building a better fortress and a better shield against colon cancer is where we need to be. So we've all got these 3 colleges, and this is our recommendation. We visualize them as catch up for these COVID missed screenings, and the potential fixes are data mining, bulk ordering, and we need to engage payers and health systems. We got to onboard the approximately 200,000 West Virginians between 45 and 49 who are going to be newly eligible for screening. Again, we're going to rely on health systems, providers, population education and engagement. So everybody better be prepping for 45. And we want to leave no group behind and intervene for disparate populations. And this lead time and more frequent messaging is critical. I would recommend you consider focusing on a community health center project. That's a critical place for these high-risk folks and equity issues. And again, men, I believe, are in equity-based issues because of their lack of engagement in the health system generally. And so some of our messages focus on those guys more so than they do on women, just based on our stats. Again, making sure that's Appalachia consistent and using focus groups. And again, earlier. So we've seen this curve, and this is our last slide. What we want to do, here's our current modality, right? We don't really do any great work before 40. We screen a minority of people who are high risk on time. We don't really sort of get into the game until people turn 50. Even then, we barely get up to 50% compliance. And over time, you know, our compliance rate's about 69% nationally. So with our new paradigm, what we're looking for is finding those sporadics out here, genetics, screening the 20% of people who are high risk that we should be screened at 40, shifting 45 to where we're getting high rates of screening at 45 because we've done a better job of leading the target in marketing, and then maintaining and sustaining a higher rate so that we can, in fact, reach 80% in every community. So I want to thank you guys for your time. Sorry about my dogs and my kids and the delivery person, but that's the reality of our world. And I hope that what we've been able to do is share some of the work that we're doing in Kentucky, as well as what we're going to be doing, because that linkage between underage 50 colon cancer and your state's issues is not going away. And if you know smoking starts in the teens, why would you start educating people about smoking when they're 40 or 50? So let's rethink this in the new paradigm. I'll be happy to take questions, and I am really honored to be with you guys again today. Thank you so much.
Dr. Jones, thank you very much for joining us today. We really appreciate it. I personally get to thank you because these changes that you made literally saved my mother's life, who was able to access early detection and colorectal screening in time to catch precancerous polyps and have them treated successfully. And so, you know, this is working, and it has a really incredible impact. We have about 2 to 3 minutes for questions. There are a few things that came up in the chat, and then we are going to break at 11:05. So I will turn this over to Summer.
Hi, Dr. Jones. Thank you so much for your time. We do have several questions and comments, and I hope that you'll be open to us sending some of those questions to you so we can send the answers out to folks if we can't get through everything. Okay,
no
great.
problem.
So the first question I have comes from Misty Arnold, and so and this might be a question you can answer. It might be a question where Mary Ellen may have to answer as well. Are polyps found during screening colonoscopies in West Virginia considered preventative or diagnostic by insurance companies?
Well, right now, many insurance companies, and again, what's really interesting about it's like a mosaic. Insurance companies have policies that you can go on the web and look at, but coding begins with the physician, and coders code what that physician writes down. And so what we found in Kentucky is insurance companies say, yeah, if they code it right, we'll pay for it as a screening. But if it's coded as a diagnostic or a therapeutic colonoscopy by that physician, that coder is going to follow through with that code and then present it to the insurance company. So what we've identified is we are going to have to go back at the provider level and start educating providers and the coders. And again, that's when you can really leverage health systems to help you, because these are internal issues that they need to work out. But again, I think it's going to start with provider education. In West Virginia, I know that you don't have legislation around that, but I think that probably nationally, based on what happened in the Medicare Act and the bill that was passed in late 2020 and 2021, where Medicare is now going to start identifying a polyp identified at a colonoscopy as continuing that code as a screening. And if not, you should push for legislation.
Great, thank you so much.
Summer, I put a link to that federal act that was passed. It's in the
Thank you.
chat.
Okay, perfect. Thanks so much, Mary Ellen. So the next question that I have is from Liz Brooks, and she was wondering if you could repeat the West Virginia stats for number 1 and number 2.
Yeah, you guys are number 1 in the nation for cases of the incidence rates of underage 50 colorectal cancer. And in terms of your burden of colon cancer, and again, this is just the statisticians would probably blow me out of the water for this, but essentially if you're number 1 in the nation for incidence and number 1 for mortality, your score is a 2. That's as high as you can get, right? And so basically it's a rank order based on that. And I would just call that the burden of it. But the more critical piece was the fact that the top 10 states that had high incidence and mortality ratios, 8 of those 10 also had very high rates of underage 50 colorectal cancer, 8 out of 10. And 7 out of the top, the next 10 folks were also in that same paradigm. So again, I'm not a statistician, and that probably saves a lot of you guys headaches. And there's more work to do on that. But I think, to me, that's a little common sense. And I think West Virginia is number 3 in overall burden of colorectal cancer behind Mississippi. Now we're number 3. You guys are number 2 overall burden, and Mississippi's number 1. But you can share that slide out for sure.
Great, thanks so much. And then one more question. So what role, positive or negative, did the insurance industry in Kentucky play in moving to those policy changes?
That's a great question. I tell you, every time we sit down with our insurers, first of all, they know why they're there. They just don't know what specific piece yet. And they all push back a little bit because no one likes a mandate. That's what they start off with. They also start off with, well, we're doing it if you guys would just code it correctly. But I would say over the decade that we've been working with insurers and payers, they've become progressively more open and willing to hear what we say. In fact, now they actually sit on some of our boards and really create a broad view of the landscape because they're now participating on either boards or in study groups around this. And like this year and this week, in May 1st, Anthem's going to come out with a restatement of their policy that will be going to providers that will mirror United Healthcare's policy. So I recommend you guys all go to United Healthcare, national policy all across the nation, read their policies around what happens when a polyp's found during a screening and how should a colonoscopy after a positive stool test be coded, because that's the ideal legislation you want to build around.
Okay, great. Thank you so much. Again, sorry we can't get to all the questions, folks, but we'll get those listed out and have Dr. Jones answer those, and we'll send it out with the meeting recording so that you have that information. It is now time for a break. So we're going to take about 10 minutes to kind of get up, stretch, go grab a snack, and then we'll be back at 11:15. Okay? Thank you.
Thank you, Dr. Jones.
Hey, my pleasure. That was great. Loved it. I'm sorry it was probably drinking from a fire hose, but a lot of data. I wanted to make sure we got it all out there.
Whitney, is it okay if we send copies of your slide set to everyone? Because I do know when you were talking about the talking card, there was a link embedded into that.
Yeah, oh, for sure, yeah. And just make sure they know that, here's the bulk of my talk, but a lot of those other ones are informationals, and, there's just no way to go through all that we're doing, but maybe there'll be some hints in there. So I don't think there's any slides in there that I'm certainly not willing to share.
Okay, thank you so much.
Just make sure that they know that those other ones they're there. So
reference and informational. Okay, great.
Oh, yeah, for sure. And if you can certainly provide them my email as well if they have any questions, they want to reach out about something that they're interested in. But I was pretty shocked about the early age onset colorectal and the state colon cancer burden. I think that really speaks to the need for a different communication strategy and advertising and the whole piece. Because just like smoking, right? You can't, why would you aim at 30-year-olds to get them to quit smoking when you could aim at, 12-year-olds to never start?
Definitely agree.
There's tobacco right there. What a great segue.
So Summer, do you have access to Whitney's slides, or do you want me to, I can save it all as a PDF and get that to you?
Yeah, go ahead and save it all as a PDF and just send it to me all at once, and that'll work perfectly.
Okay.
And then do you see the slide, do you see presenter view, or do you see the actual nice, like, Mountains of Hope, just one big slide currently?
Right now it's presenter view.
Presenter view. Yeah.
All right, I'll fix it.
And also, Summer, wanted to let you know, I have another training at 12:30. So when you get to the point about putting people in breakouts, and I won't be on the call at that point.
Okay, great, thank you.
All right, good morning and welcome back. Thank you, Andy, for providing dance music for that break. I hope everybody got a chance to be a little active, stretch, move around, get a drink of water, dance to some of the tunes that we got this time. I love that we had music during the break. If you didn't get a chance to look at them, please take a look at the slides that you're seeing during the break. Tobacco cessation scholarships are still available through Mountains of Hope, and that's a $660 value for anyone that wants to do the training in May. So if you know people that would be interested, or you think you can just talk somebody into it, go ahead and share that scholarship opportunity. Now that we're back from break, I want to introduce, in order to introduce our second guest speaker, I give you Michelle Chappell, who is the program manager from West Virginia Immunization Network with the Center for Rural Health Development.
Thank you, Shelley. And it's a pleasure to see everybody today on this beautiful April the 22nd day. Again, welcome back from your small break. And boy, what an engaging presentation from Dr. Whitney Jones. One of the things I want to just circle back around is that early age onset is a little near and dear to my heart. I was actually diagnosed at the age of 42 with colorectal cancer, and my children are very well versed in prevention and education for themselves, and also carry that message to a lot of their friends and family. So it is really important to continue to educate. And I loved that piece that Dr. Jones said, that we start educating our children with tobacco in grade school. We need to really start messaging colorectal cancer screening and family history at an early age also. So it is my pleasure to have the opportunity to interview two dynamic individuals from the University of South Carolina. But I also wanted to add on to what Mary Ellen said at the very beginning. We started doing the colorectal summits in March of 2015. This will actually be our fourth that we've been able to continue on, and it is such a wealth of information, and I really appreciate everybody coming on for this. And it's not only an honor that Mountains of Hope has always given support in providing this education opportunity, but my past work with the American Cancer Society and also with WVU for their continued support in providing colorectal summits over these last 4 opportunities. So I'm going to introduce Ms. Annie Thibault, who is the Executive Director of the Colon Cancer Prevention Network, and I'm going to shorten that to CCPN, and this is at the University of South Carolina. She oversees the development and the management of the programs pertaining to colorectal cancer across the state, with a focus on increasing awareness and education of colorectal cancer and encouraging participants in timely preventative screening to reduce the incidence and mortality of the disease. Annie is also known for her extensive work in public health and public administration, and she also has further developed and provided patient-centered navigation programs and implementation of evidence-based treatments and clinical trials. She's also one of the co-coordinators of the 2014 Southern States Colorectal Cancer Consortium, and she had joined the National Colorectal Roundtable. You might have heard Dr. Jones speak about NCCRT. Annie sits on the committee, and she serves as an adjunct faculty at the Medical University of South Carolina. Her co-presenter is Ms. Tracy Lewis, who has her degree from the University of South Carolina. And Tracy started her career in developing and implementing community-based outreach programs. And she also led a focus of healthy lifestyles and participating in timely cancer screenings, as well as providing public health education. Tracy was a past staff member of the American Cancer Society, and she is also the co-coordinator of the 2014 Southeast Colorectal Consortium. And I just want to give a plug because Dr. Jones in Kentucky will be facilitating the Southeast Colorectal Cancer Consortium virtually on July 21st, I think is what the date is. Yes, July 21st, and it'll be done virtually. And they've really been trying to engage West Virginia in participating in the Southeast Consortium. So look for that messaging, and I'll be happy to share the link in the chat box here in a few minutes. Tracy also works at the Colorectal Cancer Prevention Network at the University of South Carolina as the Community Outreach Director. It is my pleasure to introduce Annie and Tracy.
Well, good morning, everyone. It's always a pleasure for me, and I know for Tracy as well, to interact and present with our dearest partner in Kentucky. Every time we've worked with Whitney in the past, it has always allowed us to lead towards innovation, think outside the box, and completely inspire, energize, and so on and so forth. He is the one individual that I always seek to see when I go to a conference. So for all of you who may participate to any conference, reach out to him. He is a force to reckon with. So today, our talk is really going to segue very well because a lot of what we have done in our collaborations and a lot of the discussions we've done with Kentucky is think outside the box and look at different approaches to addressing colorectal cancer. And a few years back, we had several discussions about, well, how do we address early onset colorectal cancer? Obviously, we're not going to start handing out screening to anybody at an early age. So how do we focus on this? What can we do now? We are doing research to better understand risk factors, as Whitney said, but what can we do now? So this is what we're doing in South Carolina. So we're going to be talking about heightened CRC awareness through risk assessment. So one of the things that we talked about, and I love that Michelle shared her personal story, is that colorectal cancer can be different for different people. My dad was diagnosed at the age of 42 with stage 2 colon cancer. At the age of 32, I did not know his staging, but at the age of 32, I ended up with bleeding, got my first colonoscopy, had tubular adenomas, and I've been screened since. And very much like Michelle, my kids are very aware of their risk factor, and my daughter at 22 got her first screening this year. So when we are working with our population in South Carolina, we are really wanting to promote a message that they consider many factors in telling who should be screened and when, and getting providers to engage in that discussion. So we do a lot of education around screening guidelines, talking about the different modality, their strengths and their limitation, and really educating that the selection of these modality is really influenced by patients' risk factors. So with that said, we spend a lot of time educating provider and the population at large that they know their personal risk of colorectal cancer. One of our team members said it best. Very much like for breast cancer, we want people to know at an early age, even young children, that they need to get screened, right? Everybody knows the pink ribbon. We want the blue star to be just as recognized. We want people to be able to talk about colon cancer, their bowel movement, just as comfortably as they can talk about breast self-exams. So we are doing several campaigns, a lot of education. we're going into groups to talk about risk factors that impact colorectal cancer. We talk about the impact that age can play. Obviously, there's going to be a lot of work that needs to happen now with the changes in screening guideline, also endorsed by the U.S. Preventive Task Force. I agree with Whitney. We need to get really on this like right now, because it takes a while for people to be engaged. We have been educating about the American Cancer Society. We are not as quick as Kentucky has been in endorsing the age of 45 for screening for everybody. They are definitely a model to what needs to happen in all states, but we need to work on that. And then we need to look at these risk factor, age of screening, to determine which modality best fit the patient's need. One of the things that we do focus on is making sure that people understand that some screenings need to be done annually. And that is something that needs to be considered when they select a screening modality. They also have to understand, because we have done a beautiful effort at promoting that there are great screenings out there that can be done, that are less invasive, can be done at home. But we haven't necessarily done as good of a messaging to really inform patients that if they have a positive stool-based testing, that it must be followed up by colonoscopy, and it has to be done quickly. We don't want people who have a positive FIT or stool DNA to wait 3, 4, 6 months, a year, or worse yet, repeat that test before they get a colonoscopy. So there's a lot of education that still needs to be around that. People need to understand that they not necessarily have colon cancer, but that there's indicators that really need to be checked out. And then when a provider talks with their patients, because we also know, based on recommendation from the National Colorectal Cancer Roundtable studies, that a provider's recommendation is essential and very pivotal in getting patients to go on to screening. We need people to and providers to understand that their patient may have personal barriers to screening, and then these barriers can impact their compliance to annual screening, their compliance to that follow-up to colonoscopy, their barriers to going to a location to get their screening done. So these are all plenty of factors that can impact recommendation to colorectal cancer screening. And we really believe that it's a wheel that brings it all together, and that allows, if all these steps are considered, we're going to catch more patients, we're going to engage more patients, and we're going to actually ensure that people are compliant. When we talk with providers, compliance is often the key thing they say. Patients aren't compliant, I referred them, they didn't complete the test. Well, these considerations are extremely important to ensure compliance.
And so, to build upon what Annie said about knowing risk factors and what Dr. Jones said earlier about starting the conversation earlier, not waiting to start the conversation at 50, but we really truly need to start the conversation earlier, and not only just one-on-one with the provider and the patient, but really out in the community. We need to really heighten the awareness around knowing your risk factors. And so a couple of years ago, we started talking about knowing your risk and how can we promote that? How can we make it a really kind of a quick little questionnaire that individuals in the community could be provided. They can answer, go through the questions and answer it, and then know, hey, I need to take this information to my provider and have a open discussion with my provider about my answers, so that my provider will know where I currently am in regards to my risk, and also know if I need to be screened early, what type of screening modalities he can have a discussion with me about. So we developed these 4 quick questions. There is definitely a whole lot more questions you can get into in regards to risk factors with colorectal cancer, but we were really truly looking for something that we could use in the community, and even with the clinics that we work with, for them to quickly kind of assess, is somebody an average risk person, which can be given any screening modality for colorectal cancer, or if they are talking with somebody that has an increased risk, which automatically rolls them out for stool-based testing. So these are the 4 questions that we go through when we are talking out into the community. We provide these to our clinics that we work with, and we also promote this out in our education with providers. So question 1, does the patient have at least 1 first-degree family member or 2 second-degree family members diagnosed with colorectal cancer or adenoma polyps? So starting with that big question, do you know your family history? It's not just do you know your parents, your siblings' history, but do you know your grandparents? Do you know your aunts, your uncles? We also know that most people do not talk about their colorectal cancer screening among their family, not with their parents, not with their siblings. So really, truly, most patients don't even know about their first-degree family member screening history, let alone does that person, even if they knew they had a screening, does that person even know they had polyps removed? And what type of polyps? So by putting that question out there at a community event, you're talking to all age ranges. We're really trying to get this message out that really to start asking these questions at 18, 19 years old, because that is when a person is considered an adult in the medical arena, and that they should be aware of the answers to these questions. We also are trying to overcome the whole stigma that when we were little and growing up, oh, you don't talk about poop, you don't touch poop, it's yucky. So most people don't want to talk about anything that goes on in their GI tract because we've been told don't talk about it, that's something we avoid. So we really need to open those communication channels, and starting to ask that first question makes that individual start thinking about, gosh, I've never even spoken to anybody in my family about their screening history. It gives them that opportunity to start that conversation. And of course, we all know if they do have a family history, then you need to find out at what age was that person diagnosed, or what age did they have adenoma polyps removed, because that means that individual potentially needs to be screened early before the age of soon to be 45. So that way they can know that, hey, my mom had colorectal cancer at 42. That means I need to be screened at 32. So that also starts as a good conversation piece for that person. Question 2, in the past 2 years, has the patient noticed blood in their stool or had other symptoms that could be related to colorectal cancer? Well, we all know stool-based testing test for blood in stool, right? So if they've had blood in their stool, that test is going to come back positive. So they really truly do not qualify for a stool-based testing. They really truly need to be sent to a GI for colonoscopy. Question 3, now we're getting into the patient's history. Does the patient have a history of colorectal cancer polyps from a prior screening? You probably would be surprised. You may not be surprised. We have a lot of patients in our screening program that they think they remember having a colonoscopy, but then they can't remember where they had it and if polyps were removed. So you would think from all the conversations that we hear about the prep of a colonoscopy and how horrible it is to prep, and that you would, as an individual, truly remember having a colonoscopy. But we do see time and time again, we do have patients that are a little like, yeah, I think I had one of those done, and I think I had a polyp removed, or I do remember having a colonoscopy done, but I can't remember where it was. So this also makes that individual take a step back and kind of do a review of what they remember that they've had done medically. And if they can't remember, maybe it would help them start looking through their medical chart and to see if there's anything documented. And then, of course, question 4, has the patient ever had a positive FIT or stool-based testing result? Because that individual means that there has been something that's going on, and that they should have had a colonoscopy, and moving forward should always have a colonoscopy for any screening process. So these are 4 quick questions. Does it cover all the risk factors that you might want to consider for for colorectal cancer? No, but this really truly helps individuals quickly identify if they're average or slightly increased risk.
So here we talk about risk stratification. When we talk or when we think about or we talk about guidelines and when we should start screening, we are referring to average risk. And we're not often having that good discussion. What is an average risk person? Well, an average risk person is a person who has no symptoms, no signs of a disease. And in the case of colorectal, it's also a person who has had no family history of colorectal cancer or polyps. So based on what Tracy just said, most people don't even know what their family history is. So if we don't have that talk, they don't know if they're average risk or if they're maybe increased risk, high risk, or highest risk. So it is important to do that assessment because people don't know what their risk factor is. Who is at increased risk? Well, I'm a person that's an increased risk, having a personal history of colorectal cancer or adenomatous polyps, or having a family history of colorectal cancer and or adenomatous polyps, because we know that not all polyps are cancerous, puts me at increased risk. And therefore, changes the kind of screening modalities that an individual is eligible to. For average risk patients, I call it the wealth of all the screening modalities that exist right now out there is available. You want to do a stool-based test, you want a CT colonography, you want a colonoscopy, you want FIT DNA, go for it, your average risk, that's great. And that's really the bulk of the population. But for increased risk patients, high risk and highest risk, the referral to colonoscopy or GI is extremely important. Who are high-risk patients? They're patients who have inflammatory bowel disease or any type of bowel disease. These patients normally are already seen in GI and therefore probably have been screened, or that GI consult will lead to when it's appropriate for them to initiate screening. And then there's the highest risk group, which still sadly, most people don't even know if they qualify. I love that Whitney talked about genetic testing and how it's available in Kentucky. We need that in South Carolina. In fact, we need that very, very much in the South because, as you saw, the incidence of colorectal cancer is really high in the South. But that's for patients who have FAP or HNPCC. Understanding the risk from a genetic standpoint puts these people at high risk of developing cancer, and particularly colorectal cancer. Tracy?
So we're going to focus on the two normal recommendations for CRC screening, just to highlight some advantages and disadvantages. We primarily use FIT in our screening program, but this could really truly apply to any stool-based testing. So if you're partnering with Exact Science for Cologuard to do outreach, really truly making sure that those individuals are of average risk, because stool-based testing is really truly only for average risk patients. There's always pros and cons, right? So we also like to make sure that when we're in the community doing education awareness, that we always educate them about the pros and cons. And we all know that we like to have options, right? Like when I go to the grocery store, I like to have options. And I also like to look at the ingredients in a can and see, oh, this one has a lot of salt. I really want something with less salt. So really, truly making sure that the individual has as much knowledge as they possibly can when it comes to making a decision around their screening. So we do highlight the pros. It's easy, right? You can easily get a FIT or Cologuard test sent to your house. You can do it anywhere. You can do it at home. If, you can complete it at the clinic if the clinic allowed you to finish, complete your test there. We do have some clinics that do poop on demand, like Dr. Indrek does in Florida. And we've even seen some great success with that program through our screening program. FIT is low cost. Cologuard, I wouldn't put in the category of low cost, but it's definitely cheaper than a colonoscopy. You don't have any drug or dietary restrictions that you have to be take into consideration. And it's non-invasive, which for many people, that is the one advantage that they really, truly like about stool-based testing, is that it is non-invasive. So we definitely highlight those. And then, of course, disadvantages, it's only for average risk individuals. So if you have a personal or family history, if you have history of rectal bleeding, you do not qualify for stool-based testing. You really, truly need to be seen by a GI for colonoscopy. It's also something for FIT, needs to be done annually. For Cologuard, it is every 3 years. So it's also making sure that you're aware that this is not a one and done thing. It's a one thing you have to do every year or once every 3 years, versus if you go for a colonoscopy, you may be cleared for 10 years. And if the stool test comes back positive, there is an additional step you need to do in order to complete your screening, which is a colonoscopy. But sometimes people need that test result to convince them that they need to go on to have that colonoscopy. And that, as we all know, not all fits are the same. So you really need to do your homework on in regards to which fit test will best meet your needs. For us in South Carolina, we not only had to look at sensitivity and specificity, but we also had to take into consideration the heat in mailing of fit kits back to the lab, and how long that they would have to sit in the mailbox in 100+ degree temperature. So we also had to look at a kit that could endure being in the heat for long periods of time. And then, of course, always the possibility of false positive and negatives.
Can you stay there for a minute, Tracy? And so I just wanted to add something. And so one of the things that we do in South Carolina, based on what you just see, we strongly discourage clinics or our health plan to do mass mailing of fit kits. Because in doing so, they don't know who they're targeting, and they may be targeting increased risk, high risk, highest risk patients to do a fit. We then think that, oh, I'm good then, and really they're not. So we do discourage mass mailing for that reason. And when we explain this slide to them, it kind of highlights, oh my goodness, never even thought of it that way. And we always tell them there's no need for you to pay for a screening that's going to be done by a person who really should have never had that screening. And you're really creating a disadvantage, because now you're leading the provider and the GI to have a conversation that now they have to say, well, actually, you shouldn't have had this. Well, why was it sent to me? And it gets into a different conversation that should have never happened in the first place. Okay, Tracy, sorry.
No, you're good.
All right, so colonoscopy. Colonoscopy for the longest time was the only thing we talked about, right? I'm not going to even say in bracket what it used to be called, but part of the advantage of colonoscopy is that it's appropriate for all risk patients. So we, looking at some of the advantages of colonoscopy actually prevents colorectal cancer, or can prevent colorectal cancer, whereas the other screening modalities that exist can detect colorectal cancer or factors that may be associated with colorectal cancer. And why does colonoscopy prevent? Well, is one, it sees the colon, it can remove the polyps before they grow into cancer. It also provides longer screening interval, right? So if a person is getting a colonoscopy, nothing is found, they are average risk, no family history, they may be good for 10 years. And that may be appealing to people who don't like to do a lot of procedures. And they also can detect other GI conditions like colitis, diverticulitis, ulcers, hemorrhoids, everything, every other thing that may be GI involved. So, so those are some of the advantage. What are the disadvantage? Well, they're costly. They require caregiver and transportation coordination, and that is key in the South. We were talking about Appalachia before. Driving to an endoscopy center. Most endoscopy centers are in larger centers. There are more urban areas. Patients sometimes have to drive an hour, 2 hours to get to an endoscopy center. If you've done a prep, you know that you may need to go to the bathroom in that 2-hour period. And if you have to go to the bathroom and you are driving down the mountain, it may not be an option. And that's where being a woman or a man really doesn't make a difference. It's kind of hard to do a pit stop for that. And it requires time off work, right? You need to go to a procedure and you need to be there before, and you need after that to take some time to kind of come out of sedation. And for some people, time off work is it's the difference between eating and not eating, right? Especially when we're looking at lower income population. There's dietary and medication change. And for some, that may definitely be a problem. Some people, the whole idea of doing a clear liquid diet, and that is a no going there. And for diabetic patients, for instance, it can be difficult to do. Some people have problems with sedation. They do not like to be put under. There is a fear of being put under. And so just for that reason alone, colonoscopy is like the last thing they want to do. And then there's the fabulous prep. I just love it. I lose 10 pounds, it's great. But a lot of people don't like to do that. So that's a factor. And again, as I said, there's the cost. But there's also medical risk associated because colonoscopy, it's a surgical procedure. People need to understand that. It is a surgical procedure. It's not like a mammogram or breast exam. It's not like providing us stool samples. We're actually going into a procedure. We are inserting a scope in one's hiney, and there's a risk of perforating the colon. There's also a risk that if they have a polyp, it might bleed. And depending on the patient's condition, there may be anesthesia complication, especially for patients who have like COPD or maybe using some recreative drugs may be difficult. And that's it for me now.
Yeah. So we always, as like when I started talking, we talked about, when we're in the community, we use 4 questions to help really start the conversation about one's risk. And then we talk about screening modalities, and we always want to make sure that when we are really promoting that stool-based testing, that there are 2 steps with the stool-based testing so that they are fully aware and that we are not missing the opportunity to drive home the message that if that test comes back positive, that there is an additional step called a colonoscopy. And we want to make sure that they understand that it potentially could be a 2-step process, and also to address the fact that just because the FIT test comes back positive does not necessarily mean you have cancer. It just means that something is going on and that the GIs really need to go in and look to see what's going on. So, so we just want to drive that message out in the community.
So what can you do in the community? Well, we call it the do not stop at no. Continue the conversation. Again, it is not sexy to talk about colorectal cancer. You can make it sexy. You can make it funny to talk about poop. Tracy and I have done a few puns here today, but having that continued conversation is elevating people's interest and engagement. Why are they always talking about colorectal cancer? Exact Science has done a marvelous job with that little box, Cologuard, that little happy box on TV. People often say, oh yeah, colon cancer, that box, right? And that is great, right? That messaging is important. We just want people to ask questions, to continue that discussion. They may not be ready to do the test yet, but don't take no as a move on. A lot of discussions we're having with providers is, well, my patient's not interested. I've asked twice. I just don't think they're going to do it. Don't take no for an answer. Continue to talk about it. You're going to talk at maybe churches events, and people are going to be like, ooh, I'm not approaching that table. But you go year after year after year, trust me, people are going to come to you. Use time to talk about the importance of screening. Address barriers and concerns. We've just given you some tips of things that you can use to your advantage. Hey, it's simple. You can do the stool test at home. Come on, it's a one and done. You go to the bathroom every day anyway, so what's the difference? Use motivating factor. If you get screened and you find something, you can prevent colorectal cancer. It's completely, and it's one of the highestly preventable cancer out there. So you can have a healthy life. And you can also kind of guilt people in saying, if you get screened and they find something, then you can tell your kids that they need to be screened earlier and prevent them from having a chance of developing young adult colorectal cancer. And you'd be surprised how these people will actually say, okay, so I'm not just doing this for me because I really don't want to do it for me, but I'm actually doing it for my kids. And then repeat messaging reinforces the importance to individual. When we hear something over and over and over, eventually we get it. I think everybody, whether you are using tobacco products, most people know now that using tobacco products can lead to lung cancer and other cancers, right? So talk about it, talk about it, talk about it, encourage people to get screened. Don't stop at no. If they say no, find other avenues, repeat the messaging at a later time.
All right, so we kind of gave you a little foundation of what we do with risk factors and how we promote it in the community. But we really want to now take y'all to the next level and show you a snippet of what we do in regards to building awareness in the community and how you can take the tools and things that we're going to share with you in the next few slides to influence your community around colorectal cancer screening and the importance for them to get screened. And a lot of this is some of the repeat of what Dr. Jones has already said. So he kind of set us up very nicely, and he didn't even know it. So, which is great. So of course, you definitely want to have a positive messaging campaign around CRC screening, just because one, we got to overcome all those years of negativity around our bowel movements, right? I think probably most of us are over the age of 30, and we all still probably have that thought of our head of our parents saying, no, you don't talk about gas and use those words around gas. And and you definitely don't touch it. And so definitely want to make a positive spin around it. And of course, Dr. Whitney highlighted how we've transitioning how we message out to the community, right? Used to be everything came out in the newspaper, right? Everybody looked forward to getting their morning newspaper, and you would read it from front to back cover, and that was how you got your news. Or you turned on the TV set and watched the 6 o'clock news or the 7 a.m. morning news, and that's how you got your news. Well, probably none of us has looked at a newspaper in years, probably. So really truly look at how you can use social media and technology to your advantage. And we're going to show you some examples that we have put in place. And of course, humor and laughter to help remove barriers, discomfort, and stigma around colorectal cancer. We all know that humor is the best medicine for anything. So if you can make colorectal cancer a little funny, do so, because it helps rebuild that messaging that it's okay to talk about what's going on with your body to your provider or with your loved ones, to let them know about, hey, I'm going to go get the screening. I'm not so sure about it. You know, they can help reinforce that's a good thing for you to go do. Use your survivor stories, right? How many of us know survivors from colorectal cancer? Use them, not just in March. Remember, and Dr. Jones even hit on this. Yes, March is colorectal cancer awareness, but guess what? Somebody is being diagnosed with colorectal cancer 365 days a year. We can't just focus on colorectal cancer during the month of March. We need to keep the messaging and the campaigns going year round, and use your survivors at different components during the times. And even if you're looking at legislative initiatives, look to see how you can plug in those survivors to go tell your story and help advocate for those fundings, or even insurance companies. Maybe take your survivors to those meetings and talk about how beneficial it was for them to have that insurance coverage and how great it would be if they could have been screened earlier or things like that. So of course, local medias. I think most of us all know about partnering with our local medias, but always having that great relationship with that local media sometimes can help you get messaging out quicker and faster than if you don't have a relationship with them. and then influential person in your community. It doesn't have to be Chadwick, right? Like, how many of y'all benefited from, well, I shouldn't say benefited, but how many of you had used the death of Chadwick to influence or educate people around colorectal cancer? But it doesn't always have to be that high level of an individual. It could be a coach, it could be your mayor, it could be the minister at the largest church in your community. I live in Rock Hill, South Carolina. We are known as the football capital of the world. We have produced more NFL players than any other city. So who do you think are really important people in my community? It's our coaches, our football coaches from our 3 high schools. And anytime you mention their names, everybody's like, oh, you were with that person last night, you know? And we have the Panthers coming, their headquarters are coming to my city. But think out of the box. Who are those influential people in your community, but also in the community that you're trying to target? And then, just like y'all are here today, because y'all have organized a state level consortium to look at colorectal cancer. So where else can you spur these ideas in your community? If it's bringing several counties together, or bringing the whole state back together and looking at can you replicate what Dr. Jones has done in Kentucky? Or do we need to start at a smaller level because of in your state, it's easier to get laws passed or things passed at a county level or a city level? So how can you work the best and get things moving forward in regards to colorectal cancer screening?
So again, to go back to some of the things that we have done around messaging. So a few years back, the National Colorectal Cancer Roundtable developed a messaging toolkit. It's on their website, so feel free to visit it. And maybe Michelle, you can put it in the chat box. But one of the recommendation in the toolkit was that there was a toolkit for Latino. And in the Latino, they said that one of the way that you can reach out to the Latino is to really involve their family, and how can it make a difference for their family. So we developed this campaign, and here you see a snapshot, but it's actually also in a PSA video that we've created. And it's basically this young grandmother, or soon-to-be grandmother, who was diagnosed with colorectal cancer. And she was diagnosed early, which allowed her to avoid chemotherapy and radiation. And now, because she was diagnosed early, she gets to be a grandma. Very, very positive messaging. And you can segue that into also educating the daughter of this lady that, you know what, since your mom had colorectal cancer, you need to start being screened earlier. So do the messaging around positivity. Colorectal cancer is one of the few cancers that is highly preventable or easily treatable if detected early. So do your screening early. You won't have to deal with the consequences of cancer treatment.
And Annie, I'd like to tag along in regards to this. Was something that the CCPN developed several years ago. And actually, we just recently were reached out by a group out in California who has a high Hispanic patient population. And they had seen our the video that goes along with this postcard, and they want to use it within their population because it was well received. So just also don't think just because you've developed a campaign a few years ago that it's still not relevant to today. So just also think about what you have developed in the past, and did it have great messaging? Did you get positive feedback from it? Is it something you should bring back and look at how you can spoof it up and put it on social media versus in the different platforms that you had used previously with that campaign?
And I'll segue again from that to Tracy in saying the colorectal cancer community, prevention community, is tight-knit, and we like to work together. We believe, especially in the South, in the rip off and duplicate. That was well said by Senator Alexander. Rip off and duplicate, or R&D. is about reaching out to your partners and saying, hey, we saw that you have this tool. Do you mind sharing? Can we adapt it? And work collaboratively. So this group in California is saying, hey, we'll translate these in Spanish. We did not have that resource when we developed this material. And they in turns are going to work at that translation and share the product that's translated back to us. So it's a win-win-win. Slide.
So a lot of conversation today has been around that early age onset and how do we reach out to them? How do we increase awareness? So we've actually looked at our marketing pieces and making sure that we have things that resonate with that age group. And so as you can see, here's a couple pieces that we've developed to use to attract the attention of the younger population. We use very, very diverse groups of ages and individuals. So we're not just targeting one race or ethnicity. We're trying to target a specific age group and hit all age and ethnicities. So these are some of the pieces that we really good response in it. And also drawing the statistics. 1 in 5 people who develop colorectal cancer have other family members who have also been diagnosed. So that's driving home that, start the conversation. Oh, 1 in 5, there's 10 of me, there's 10 family members.
Oh, you cut out. You're gonna have to repeat that, Tracy. We missed that last part.
Oh, okay. Can y'all hear me? I'm sorry. Maybe okay. So we also drew the statistics on this card, 1 in 5. So if you are a family of 5, that means 1 of you would have it. If you have 6 of you or 10 of you, that would be 2 of you. So that makes you think about, oh my goodness, I don't know who in my family has it or who's had screening. So let me have that conversation. I might need to have that conversation because I don't know. So this is also sparking that individual to go back and talk to their family too. All right.
So again, Whitney said it best. It's time to use the social media, and especially in this past year, it has gone viral, and that's what it wants to do. People are on their social media platform all the time. TikTok is like super cool right now. So use those. And the beauty of these platforms is that it does not need to be a polished product, right? We're watching people in their house with their dogs jumping, licking ice cream. We're looking at grandma dancing in her kitchen. And all that is unpolished, but it drags and it catches our attention. So this year for our Colorectal Cancer Awareness Month, we used some of our team to do these little quick tidbits of videos that they posted, and we promoted them on our platforms. I'll let Tracy show you how easy it was.
Yep.
Hey, did you know that African Americans are 20% more likely to develop colorectal cancer and 40% more likely to die from it? That is why it's important for you to talk with your doctor about when you should be getting screened. Remember, it's your call of duty to check your booty. Talk to your doctor.
So this year, actually last year, we started this campaign, and we wanted something that would attract a larger population. And we wanted a campaign that, you know, we talked about tongue in cheek, make fun of it, like make it easy, make it like engaging. So we created this campaign, and it's called It's Your Call of Duty to Check Your Booty. Again, using all kinds of things that would attract attention. People have been home playing their Xbox and PlayStation and Call of Duty, you know, like that's a game a lot of people know about, they could relate to. Booty, we use the word and we put it out there. It just kind of, we wanted something that resonated, that was easy, that would put a smile, and I've seen a lot of smile when I was looking at the gallery just now. That, it resonates, it sticks, and it kind of makes the whole idea a little less, you know, taboo. Also, there's a lot of things in this image. A lot of you may have seen the Love Your Colon tagline that exists for a long time. We brought that back, the upside down art or your butt. You know, there are all kinds of messaging that way that you can do that people pick up on. Some are more visual, some are more auditory. You know, use these and make it easy. So these slides took us to create less, like basically our staff just took their phone, recorded themselves on Zoom platforms, on FaceTime, shared with our team. We added a couple PowerPoint slide to it, and up it was done. So it wasn't something complicated. It wasn't something that cost a lot of money, but it drove a lot of messaging, and a lot of people found them exciting and fun to look at.
And then, of course, we've talked about humor, and I'm not sure how many of you have seen the Sharon Osbourne video that she did with partnership with the American Cancer Society, but of course, she is hilarious in herself, but she made a great video. We also use humor when we are navigating our patients through our patient navigation program, but we thought to bring a video into this presentation to show you how easy it is to incorporate humor. So we're going to show her quick video real quick.
Tiny, tushy, badunkadunk, call it what you want, but talk to your doctor, because the American Cancer Society says colon cancer is the leading cause of cancer deaths in the US. I was diagnosed with colon cancer, but I might have avoided it completely if I just had my kidney checked. So get off those juicy doubles and go get your rump shaker screened so you can say you literally saved your own life. Can we change badunkadunk?
So as you see, she gets her message across in a very light-hearted, funny way. She used all different kinds of names for your bottom. But, you know, her message was, get off your bottom and get it screened, right? And so sometimes people just need that light-hearted message to serve as that reminder, oh yeah, I haven't had that done yet. So, and anytime we can make ourselves laugh, makes us feel good.
And then we talked about using your local champions. So in South Carolina, one of our key news anchor is Ms. Dondi Mercer-Plank. We engaged her several years back to help us create awareness around March about colorectal cancer. And she has become one of our biggest advocates. And she will take a lot of opportunity to talk about colorectal cancer throughout the year, not just during March, but in March, she usually tries to have 2 or 3 platforms during her sessions that are actually key, like not a 30-second clip. This year, she had a 7-minute interview with Dr. Berger, who's on this call today. Dr. Berger is a force to reckon with. He created the Center for Colon Cancer Research at the university and is the founder of the Colorectal Cancer Prevention Network. And they talked about, you know, educating the people, the science, what's out there, what's coming up. And you know what? That works every year. People write back to Dondi, they write back to Frank. She posts her interview that's on the news channel on her Facebook channel. And it's been retweeted by many organizations in our states that do work around colorectal cancer, gastroenterologists, our cancer alliances. So use your champion, because people, they are compelled by them. They know these people, and while Dondi, many may not know her personally, she's part of their living room because she's on the news that they watch every day, or they're watching on the web, and so they know her in that way. So using your local champion usually gets a lot of messaging out. And once we got her really engaged in our group, she was so funny. A couple of years back, when she was 49, she challenged Dr. Berger in saying that she was turning 50 the next year and that she was going to make a big to-do about getting her colon cancer screening. And Dr. Berger challenged her to be part of a prep colon party. And so basically, when she turned 50 and she agreed to this, we did a webcast throughout the whole news, the news webcasts at 6 o'clock, where she was prepping for her colorectal cancer screening. We had people come, we had 5 individuals taking their prep and martini glass and showing that it was really not that hard and that you can make fun of that session. After she took her prep the next day, in the morning news, we followed her going to the endoscopy center and then waking up from her colonoscopy to hear that everything was good and having a scrumptious breakfast, because that's the pay that you get for having done a clear liquid diet. And that drove so much interest, so much interest. Okay.
So how can you have an impact? One, encourage CRC screening participation. When you're out in the community, when you're in your church, when you're talking to your colleagues, don't miss an opportunity to encourage colorectal cancer screening and knowing your risk factors. And of course, educate. I think all of us on this meeting today, we are educators at heart. And so don't miss an opportunity to educate about risk factors, knowing your risk factors, and about the options of screening modalities. And if you don't know all the screening modalities or know enough information, just encourage that individual to talk to their doctor about what screening modality is the most appropriate for them. And then target messaging based upon the population you're trying to reach. As Annie highlighted, the NCCRT has really spent a lot of money on focus groups about what messaging resonates the best within Hispanic, African American, Asians. Go on that website, look for their resources, because they really truly have developed verbiage for those specific target population. I think they may even have something out on Appalachia. I may be wrong, but I do know that that has been an area of focus for many years for ACS, and of course, Dr. Jones, and I know for West Virginia. And I love Dr. Jones's campaigns when he shared them with us. I was like, oh my gosh, I think there's some of those we can take for South Carolina, because we've got a huge group of hunters and outdoors enthusiasm in South Carolina. So they would actually resonate with our population too. So also, like Annie said, we are a very collaborative group. We're a small group, and we love to share ideas and R&D. So if y'all are doing something that has had great response, share it. Let us all know so we can kind of R&D too, because together we can be impactful and make a true difference. And then, as we've talked about today, addressing that patient's barriers and remove the stigma. Barriers are really, truly one of the biggest issues that we have in the Southeast in regards to patients completing screening. Either it's transportation or the distance that they have to travel to reach an endoscopy center, or even a surgeon if you're using surgeons in your area. That is a big barrier to address, but how can you think outside of the box? I know in Kentucky, y'all used to have, and you still may have, in the screenings on Sunday. And how did that address an issue? We also know that still-based testing, and listening to Dr. Jones talk today about the new things coming out, how is that really going to truly impact the messaging, and how maybe that may remove some of our rural area barriers, so really thinking out of the box on how we can use the new technology and messaging that out, and how it will impact our numbers at the end of the day, and how many people we're going to save because we're able to educate and get those tests to those individuals. And removing the stigma by talking, right? Like, how did people remove the barrier around breast cancer? It's because we had people just talking about breast cancer all the time. So, as I said, don't let colorectal cancer only be focused during March. Make it a year-round campaign and conversation. So remember, start the conversation, encourage the conversation, encourage people to understand their own individual risk factors based upon their family and their personal history, and then encourage them to talk to their physician, because at the end of the day, it's a conversation between that person and their physician about which screening modality is the best for them.
So talking about some of the things that we have done, we're happy to share. Education is key, as Tracy just shared. Make that education fun. There's all kinds of ways to do it. We've been partnering with a lot of people across the nation and talking with a lot of people, talked with some folks at the Stand Up for Cancer group who had done some pretty good studies around the benefits of using cartoons to educate people on cancer. It takes away the stigma. It also takes away of a lot of the stigma around racial and cultural disparities. Most people associate with cartoons. And so after having these discussions, again, R&D, we went back and we sat as a group and we wanted to take tidbits of information that we thought were a big focus around colorectal cancer to talk about risk and talk about who and what should be screened. So we have developed, I think we have 10 of these videos. And more to come. And actually in some of our partnership right now with Kaiser Permanente, they will eventually be in Spanish as well. But just to showcase how you can make a short video on a lower budget that is impactful. And just to add to that, that many of our clinics are using these videos in their wait room areas. Some navigators are using them for education to help patients be compliant.
The age you begin colorectal cancer screening should be based on your risk and current guidelines. Your doctor will review your risk based on your family history of colorectal cancer or colorectal polyps, including when they were diagnosed, any symptoms you may have, and your age. In some cases, your doctor may recommend genetic testing to see if you have an inherited condition that increases your risk even more. Talk to your doctor to find out when you should start getting screened.
So again, these are shorts. They include a lot of information. It's about the discussion. The more people see information on colorectal cancer, the more it's going to entice them to ask questions about it and hopefully get screened in time.
And this is our, go ahead, Annie.
No, go ahead.
I was going to say, this is our team, minus our navigators. And actually, we are missing Dr. Berger on this slide. So we had one update and kind of, I think, messed things up. But anyways, this is our team that, of course, Annie and I presented today. Samar is our new patient navigator manager. He joined our team 2 months ago. Many of you probably have met Renee Caldwell in the past. She left us at the end of January to relocate up in Indiana to take over her family business. Lisa Scott is our education manager. Marsha Clark is our communication director, and she is one that's really responsible for a lot of the graphics and design that you saw today that we shared. And then Janelle Autry is our business manager. So that is our team. And then we have 8 navigators throughout our state that navigates patients to screening.
So if I can add to that, go back quickly. If I can add to that is, if there's one thing we have found very effective in a lot of our outreach efforts, awareness, education effort, Marsha has been pivotal for that. It is the one thing that, she has helped us. She has helped many of our partners as well with some of their material. But having someone who stays on top of social media, someone who is aware of new things coming up the pipeline, and how to communicate effectively. If you have someone that's got those skills, and I mean, she is so good with InDesign and the development of videos. If you have that ability on your team, that is a definite plus.
All right. Open for questions.
Thank you both very much. We probably have time for 1 or 2 questions. Summer?
Yeah, so thanks again. We're very excited. We'll have to send you some questions and have you respond to us so we can send it out to the group afterwards. But one question I wanted to highlight is looking at Stacey Wenger. So she's personally had resistance from some providers to screen under 40 years old with any of the ways that you had shared. So when there are, particularly when there are concerns, and they have no family history, how should patients best address those concerns with their provider?
So just to be sure that I understand the question, we're talking someone who may be having symptoms or GI issues.
Yeah, it sounds like basically GI issues, but no family history. Yeah.
Okay. Well, obviously, this is part of demystifying the discussions around talking about GI issues and not putting them taboo is going to help people talk about their bleeding problems, their diarrhea problems, their cramping and bloating problems, their farting problems. A lot of people don't use these terms, and as I'm saying them, maybe some of you are cringing. Did she say fart? Yes. As we educate, if we use some of these words, we're actually letting people feel comfortable about having these discussions. What you're discussing is definitely a barrier, and in younger people, there's also sometimes the fear of cost associated with it. They certainly, if providers start having a discussion about colorectal cancer at an earlier age and risk factor, their patients are likely going to be more inclined to wanting to have these discussions. That is actually partially why we are encouraging the 4 questions with our providers. Many of them in South Carolina have actually integrated the questions in their EMR, and their medical assistant, when she takes the patient's weight and height and all that fun stuff, ask the questions, it actually opens the door because people aren't comfortable to go out talking about these things. So by opening the door, do you have signs and symptoms that could be associated with colorectal cancer? Like what? Diarrhea, bleeding? Oh yeah, actually, I didn't know how to talk about this, but yes. So by opening the discussion, you're allowing people to talk about something. It's very much like mental health. If we tell people that it's okay to talk about mental health, they're more likely to want to share. It's the same thing with GI. So by opening the discussion, these patients are more likely to talk with their provider. And in this case, obviously the patient needs to be referred to GI consult.
All right, well, thank you so much. So it's 12:20. Like I said, I'll work on gathering these questions and send them out to our speakers to get some feedback, and I'll include them with our following the meeting with the recording. Right now it's time for a break. So we're gonna do a 30-minute break for lunch, snacks, things like that. And we'll return at 12:50. During this break, I'll have some slides up that include information about our Ribbons of Faith training, tobacco cessation scholarships, the cancer plan and how you can order it. And I think there was one more the next colorectal cancer screening summit event. So keep an eye out for those, and we'll see you back here at 12:50. Thank you.
Summer, is the meeting still ending at 1:30? Okay, thank you.
Thank you. Thank you, everyone, and we will see you next time.
Thank you.
Thank you.
Bye.
Bye-bye.